Good evening. My name is Caitlin Polachek and I'm with Cook County Health. Thanks for joining us. If you need help with an appointment or you have a medical question, you can reach out to our health system at 312-864-0200. That's 312-864-0200. My guest tonight is Dr. Jacqueline Harrison, and she's a attending physician at Cook County Health in our Colorectal Services Department. Thanks for joining us.
Thank you, Caitlin, for having me.
Can you tell us a little bit about your role at Cook County Health?
I'm an attending surgeon in the Division of Colon and Rectal Surgery at John Stroger Hospital and have been there since 2009.
And what led you to come to Cook County Health?
Well, I did quite a good portion of my training at County Hospital in conjunction with Rush. So I had a strong attraction to the patient population and the kind of work that they do.
Right. Thanks. So March is Colorectal Cancer Awareness Month, so I have a couple questions for Dr. Harrison. First of all, how common is colorectal cancer?
Well, in the United States, there are about 150,000, roughly 150,000 new cases diagnosed every year. The death rate is about 50,000 per year in the U.S., so that translates to about a 4% chance, 4 to 4.5% chance, if you have an average risk of developing colon cancer in your lifetime, if you have an average risk, which, in other words, is about 1 in 24, 1 in 25.
Mm-hmm. What does an average risk mean?
So that means basically that you don't have a factor that puts you at an increased risk. In other words, there are a few. Family history, for one, especially if you have a first-degree relative, in other words, a sibling or a parent or even a child that has colon cancer. And especially if that relative was diagnosed with colon cancer at a young age. Certainly less than 60 and especially less than 50 puts you in an increased risk. Inflammatory bowel disease, such as Crohn's colitis or ulcerative colitis, certainly incurs a higher risk than the average population. And there are some well-known genetic syndromes that can be tested for easily, that can be tested for with DNA testing, specifically hereditary non-polyposis colon cancer syndrome, HNPCC for short, or it's also called Lynch syndrome is one of those, and the other one is familial adenomatous polyposis. Those are the two most common, well-known inherited syndromes that put patients at increased risk.
Mm-hmm. Okay, so are there signs or symptoms associated with colorectal cancer? Like if I had colorectal cancer, would I necessarily know?
So there are signs and symptoms, especially, but that depends on which part of the colon the cancer is in.
Okay.
So if you're talking about a cancer that's near the end of the colon or on the left side of the colon, those can present with bleeding, changes in bowel habits, either diarrhea or constipation that's new in onset, abdominal pain, bloating. Those are sort of late signs of colon cancer. If we're talking about cancers that are on the right side of the colon or towards the beginning of the colon, those tend to present with signs related to chronic blood loss. So fatigue, shortness of breath, and anemia, signs and symptoms of anemia, those related to the chronic blood loss. And it's not unusual for us to get a few patients every year that present with heart attacks, basically related to their severe anemia. But signs and symptoms tend to present relatively late unless you have a cancer that's pretty close to the end of the colon, in which case those tend to present earlier with bleeding.
Makes sense. Does diet play a role in developing colorectal cancer?
So, Caitlin, that's a really complex question. The short answer is it probably does. we think that a diet high in fiber and fruits and vegetables and low in red meat and processed meats is probably protective for colon cancer, but there are a lot of complicated factors that make dietary factors very difficult to study, to really study, because they tend to go hand in hand. In other words, if you have a poor diet, eat a lot of red meat, a lot of processed meats, then you may have other risk factors such as smoking or alcohol use that tend to go hand in hand and sort of complicate the picture.
Okay. How does screening save lives?
So, like we said before, those signs and symptoms that we were talking about tend to come relatively late with colon cancer. So, screening tends, the idea is to pick up either early cancers or polyps before they ever even have a chance to turn into cancer.
And what age should people start getting screened?
So up until a few years ago, we were saying 50. If you're average risk, then you should start at age 50. But now the American Cancer Society has lowered that to age 45.
Okay. And if screening works, why do you think that, or why from a doctor's perspective, would you say that more people aren't doing it?
They don't know enough about it or really understand the rationale for doing it, that we're trying to pick up polyps at a stage where they can be removed easily during the colonoscopy, or finding polyps by other methods of screening to get you to a colonoscopy to where the polyp can be removed, or if you have a cancer already and it's detected by screening, to detect it at an early stage where it can be easily treated and cured.
Okay, and why, can you reiterate why people remove polyps if they're not cancer? Is it because that is what can form cancer?
Right, exactly,
Okay.
in a nutshell. So most, not all, but most colon cancers start out as polyps.
Okay.
And they tend to get bigger if they're left there, and uglier, and eventually can turn into cancer. We don't necessarily think that, some of the polyps we think maybe some of them regress on their own, but a lot of them will stay there, and some of them, a certain percentage of them, will eventually go on to form cancer.
So are there different types of polyps?
Yes, there are, that can get sort of really in depth, but there are adenomatous polyps, which have subsets. There's tubular adenomas. Those are the most common polyps that we worry about, as well as tubulovillous adenomas, etc. And there's also non-adenomatous polyps that tend to be ones that are less of a worry, such as inflammatory polyps or hyperplastic polyps. But usually when we see a polyp on colonoscopy, we remove it because we can't necessarily, we have a good idea with the naked eye, which kind, but we're not always correct. And so we, usually when we see one during a colonoscopy, if it can be removed, we'll remove them, retrieve them, and send them off to be tested.
And so there are polyps that are like more prone to forming colon cancer and more that are more benign.
Right.
Okay.
So hyperplastic polyps, especially ones on the left side of the colon, tend to be something that for the most part we don't particularly worry about at all. And oftentimes, if we remove those during a colonoscopy, we won't recommend that you come back any sooner than 10 years. Okay. Whereas if we're taking out adenomatous polyps, those are the polyps that we worry about and we want to get out of there. If we find, 3 or more, or if we find large polyps, then oftentimes we'll tell you to come back in 3 years or 5 years for another colonoscopy.
And so after someone starts getting colonoscopies, how often should they get them?
So that all depends on the findings at their first colonoscopy, and also if they have, and we're just talking about average risk the average risk population. So say if I do a colonoscopy on you and you're 45, okay, and I find a 1.5 centimeter polyp, adenomatous polyp, because that's a large adenomatous polyp, that qualifies, or that puts you in the group that would need to come back in 3 years.
Okay.
If I remove a 0.5 centimeter, 5 millimeter adenomatous polyp, then oftentimes we'll tell you to come back in 5 years. If I do your colonoscopy and the prep is pristine, I can see everything, I got a really good look, then, and you have nothing, you have no polyps, then 10 years if you are average risk.
That sounds pretty good. So what are people's options for screening? Is it just colonoscopy?
So colonoscopy, I'm biased because that's what I do a lot of. But colonoscopy is the gold standard. There's a lot of advantages to colonoscopy. The main advantage being that if we find a polyp, we can remove it. Whereas the other screening tests, we can talk about those, but the other screening tests, if they're abnormal or positive, then you need to go on to get a colonoscopy anyway.
Okay.
So other screening tests include FIT testing, or fecal immunochemical testing, which is along the same lines as fecal occult blood testing, where you get a kit from your physician and with instructions, and basically involves submitting some stool samples, and they test it, and if it comes back positive, then you should be referred for a colonoscopy. Those are for average risk patients. Those are not for people that have a family history or a history of inflammatory bowel disease or anything of that nature that puts them at an increased risk. Let's see. Other tests, virtual colonography or CT colonography. Basically, that's kind of along the lines of lower GIs, but with CTs. So they're a little bit, you can see a lot more definition, etc. But so those are some of the other screening methods.
Okay. And then how can people go about finding a screening facility or surgeon?
So your first resource would probably be to ask your primary care physician.
Okay.
And then if you don't have a primary care physician, then like everything else, I would Google it. Colonoscopies
Find a place near you or somewhere that your insurance will cover if you have insurance.
Right.
Can you talk about treatment options for colorectal cancer?
So once you're diagnosed with a colorectal cancer, and so we say colorectal cancer, implying there's one's of the rectum, which is about 1/3, and one's of the colon, in other words, 2/3. Cancer in the rectum is that's changing. The treatment of that is changing at a really rapid pace, and it's already much more complicated and involved than treating colon cancer. So rectal cancer, oftentimes, depending on the staging of the rectal cancer, that can entail getting chemotherapy and radiation to sort of shrink the cancer, followed by surgery. But that whole, the arena of rectal cancer treatment is really changing at a rapid pace. Colon cancer, so the first step once you're diagnosed with a colon cancer by a colonoscopy is staging. So usually the staging involves a CAT scan of the chest, abdomen, and pelvis to determine whether or not the cancer has spread to the lungs or liver and whether it can be cured with surgery. And basically, at this point in time, surgery, it would be the mainstay of treatment if it's not spread to other organs.
Okay. Do you have anything else you want to add, or anything else you want to tell the viewers at home?
So we didn't really talk about colonoscopy and why the reasons more people don't get colonoscopy. So the disadvantages of colonoscopy are, it's invasive. So there is more risk involved with colonoscopy than there is with, swishing a brush around in the toilet and sending it off somewhere. It's invasive. So the main risks of colonoscopy are bleeding and perforation. Okay, bleeding is probably is much more common than perforation, which is really serious. But bleeding, if it happens, which is still, even though it's more common than perforation, is still pretty rare. It's very treatable. Okay, perforation. When I consent patients for colonoscopy, I basically tell them one of the risks is perforation, meaning that we would somehow put a hole in your colon while we're doing the procedure, and you may need surgery to fix it. Okay, so obviously very serious if that happens, but it's very, very rare. But the main reasons that, besides the invasiveness, and I think some patients are embarrassed, maybe embarrassed, but they've also probably have family, friends, etc., that have had colonoscopy, and so they've heard about the prep.
Yeah.
So
and the prep is
that's
an entire gallon, correct? Is it still?
We still use the entire gallon for the most part at Stroger, but there are patients that simply cannot tolerate a prep or have some other reason why they can't take the gallon prep. That's unpleasant, not to mention. So basically, the instructions for colonoscopy for many patients involve some variation of clear liquids the day before, so you can't eat any solid food the day before. And then you have to drink this gallon of usually most people don't find it very pleasant tasting liquid that basically is like a car wash for your colon, and you'll be in the bathroom all night.
Yikes.
Yeah, yikes. So what I tell patients a lot of the time is that the prep is usually worse than the actual procedure itself. The procedure itself, so then once you're cleaned out, you show up and nurse asks you a lot of questions. You get in the gown, etc., and you get an IV because you get sedation for the test. So you have to bring somebody with you for the test. That's most places.
You need a ride home after sedation.
You need a ride home, yeah. Even if you're taking a bus or taxi or whatever, somebody over 18 has to be there to take you home afterwards, and that's how most places function. So that can be a problem with our patient population. Sometimes even if they don't have anybody.
Yeah, and I'm sure at every place that's an issue. Just because if you have to go and get it on a Monday, your mom or dad or your brother, sister, or your significant other has to take off work to come get you. Right. So I'm sure that's a common issue.
Right.
But yeah, thank you so much for joining us today. Again, if anybody needs help with patient care, you guys can call our patient support center at 312-864-0200. That's 312-864-0200. Dr. Harrison, it's been a pleasure. Thank you so much for educating us today.
Thank you for having me.
Have a good one, everyone.